Hi, Jennifer. Thanks for
Hi,
joining me.
hi, Walt. Thanks for having me.
Absolutely. These peer-to-peer videos that I've been doing have been really popular I think with new learners, especially, and that's what they're intended for, to give that person who comes out of the class going, okay, that's cool stuff, but I don't know if I can pull this off. How do I do this? And that's exactly what we're trying to glean from you today. You're kind of a serial repeater when it comes to my classes. At least as a teaching assistant, you have been so generous in giving me your time for all of the Bay Area classes to help me out with the workshops, and I am so greatly appreciative of that. But tell our audience who you are, where you work, etc.
Great. Well, it's been my pleasure to help be the teaching assistant for your classes. So thank you for asking. My name is Jennifer Kizner. I'm a speech pathologist at Stanford Healthcare. I have been a speech pathologist for going on 27 plus years. I'm currently working in the head and neck oncology multidisciplinary clinic. And I get to work really closely with my surgery, radiation, and medical oncology colleagues. That's kind of the big picture. I've been in that specialty for the last 8 years or so.
Great, great. And you took the class originally when? About
You know, maybe it was like 8 years ago, seven,
yeah,
8 years
yeah,
ago was,
yeah. And that was before I sort of rebranded and really kind of put myself to task with coming up with more evidence to support the work. It was pretty I don't know, I guess it was loose. It was loose. Um it was rather freeform back then. But hopefully I provided more relevant research and a model that is supported by not just the speech pathology profession, but evidence-based practitioners all over.
yeah, and what I would say is what I really appreciate about your courses, I've been, like you said, a repeat offender, but every time I go to your class, I come away with something else, and I do manual therapy as part of my practice. So even though I'm going back to these classes, you keep tweaking them and making them better and really more user friendly for the clinician and maybe the novice clinician who hasn't had a lot of experience with hands-on work in the speech pathology realm.
Yeah. And I know that you certainly turned me on to, well, we introduced the concept of doing the stretch down here, and you gave it a title which I've totally stolen, laryngeal anchoring. And not only did you give me the title, but you're allowing me to see a little bit through the lens of the speech pathologist on how you took that and modified it to whether it's how your brain works, how your patients work, whether it's the facility in terms of actually coming up with, that sort of do 10 of these type of a protocol for it. You want to talk about that just a bit?
Yeah, so I think when we talk about exercising the throat muscles, it's so different than exercising your arms and your legs, right? These are intrinsic or inside muscles. So we have to be a little bit creative in how we access those muscles in order to improve function, right? So after I took one of your courses, I think we were doing, really deep stretches. And I think I was kind of playing around with the little blue dicem that I love, that kind of sticky, flexible material. And I kind of anchoring down at the base of the neck. And then I just started to try to swallow when I did that. And I said, oh, this is like swallowing against resistance. So by just anchoring down on the skin and tissue, whatever we're anchoring down here,
Yeah,
and
yeah.
then swallowing, and your swallowing muscles are moving up and forward, and we're anchoring down. It gave a level of resistance that I thought was a little bit more intense than just doing what we typically do, which is an effortful swallow maneuver or an
Mhm.
effortful swallow exercise. So to the point where I am kind of in the beginning stages of devising a study where I'd actually like to see if there's a difference between doing just an effortful swallow versus an effortful swallow against resistance with result to functional outcomes for swallow. In my
Absolutely. And yeah, sorry, go ahead.
no, in my patient population in the head and neck cancer patients.
Yeah, and I so admire and appreciate your wanting to take this and put it into the research realm to actually see if it works, see if it can be effective from that evidence-based perspective. Speaking of evidence-based perspective, there was a paper that was just released earlier this week by Daniels, a survey of manual therapy techniques and protocols used to prevent and treat dysphagia in head and neck cancer patients during and after radiation therapy. Man, I thought I was wordy, but great paper. It's a number of the research have done in a lot of preliminary survey type articles. This is another one, and near the end of it, they call for you know, the that SLPs are using this work. They're saying it's effective, but we don't have the studies, the RCTs to support it, and that a protocol is needed. And I could certainly respect that, and I understand that. And I'm sort of, I'm not anti-protocol, but I think that the protocol misses that N of one experience that our patients often give us. And do you have any comments on that?
Thinking back to other articles regarding exercise protocol in the field of speech pathology, I think that we are lacking with dosages and frequencies for different exercises and what will give us the results. So maybe that was a provocative paper that was put out there to try to get speech pathologists to, like you said, do more of these studies that are
Yeah.
larger volume. And again, I don't know all the literature in the physical therapy world, but I know that we definitely don't have as many RCTs as, other fields. So I think I'd love to read that article, but just kind of from your thoughts, I think they might be trying to encourage people to get more standardized care or dosage and frequency of treatment recommendations. But after taking your courses, I mean, it's not a cookie cutter response to every patient, because they're all going to come to you with a different set of issues and time availability that they can do these exercises. So I do think that you have to, it's a patient-centered care, and we really
Yeah.
have to take what the literature says and try to, put it out there to our patients where they can tolerate it and try it.
Yeah. And I'm actually I'm totally on board with that in terms of the need for a protocol, at least for the sake of the study, to say, okay, we tested these two. I totally understand that need, and I also, I respect the need to be individualized with shared decision making with patient-centered care. There is so much evidence to say we have to be flexible within the protocols
Yeah.
to meet those N of one experiences that our patient actually represents. So I'm not against the protocols, and was just kind of curious as to your take on it. What
I,
you describe. Oh, go ahead. Sorry.
I was just going to say, sorry. I think when you think of protocol also, when you do a study, you have to have a protocol,
Yeah.
right?
Yeah.
But they don't know that if that protocol does work and they have good outcomes, they don't know that that's the only protocol that would work for a patient, right? They're just saying
Yeah.
that this study showed if you do, 3 times a week, this many repetitions, there were gains in function. But we don't
Right.
know if less does the same, or so I think we all kind of take what we see in the literature with a little grain of salt and try to do our own little N of one, offshoots of what we read in the real world.
Yeah. Not necessarily in your literature, but in broader literature, I see so many studies that, let's just talk about the diaphragm related to GERD, where they did, okay, 4 or 5 techniques, and then, that proved to be effective. Then the protocol would say, well, then we have to use those 5 techniques. But nobody actually drilled down to say, well, did all of them really affect it? Were all of them necessary? What about if we inserted other things in there? And I understand those are the demons we all fight with when it comes to the RCTs and evidence base. But I really applaud that this study coming out and saying, this does show promise. And there was even a nod in the paper to my rather patient-centered perspective that I'm going to be blunt. I did not read the whole paper. I read the intro and the conclusion, which is what most of us read, right? But it just came out, and I haven't had a chance to read it. But I wanted to just throw it up against what we're talking about here.
Can I make one? I'll make one more comment about that. When you do a study and you're focusing on one exercise, the patient's only doing that one exercise, right? And typically, I mean, in my practice and others' practice, I think we don't, there might be a few exercises, right, that we're giving them. So
Yeah.
I think you have to kind of take that perspective too, that we might not only start with one exercise for 6 weeks, we might give them a few things to start with. And so that's
Yeah.
more real world. Yeah.
I want to just rewind a second because when you were talking about we were talking about your laryngeal anchoring, you did what I encourage every clinician who comes to the workshops to do is this is not the protocol. Here, here's a template, here's ideas, and I want you to go and make it your own. And that's what I just so appreciate and respect about you in terms of how you took that and modified it for all the various reasons that you mentioned, because it's not just about here's how you do this work. To me, the most important aspect of my classes are the shared decision making, and we just apply it through the lens of manual therapy. But people still want to learn that sense of touch and call it manual therapy or myofascial release or laryngeal manipulation, whatever you're talking about. So I just wanted to point that out, that I respect that greatly. Um, in terms of this peer to peer, what advice might give to a new learner or somebody coming back to the work? Is there any advice that you found challenging in the beginning, for instance?
I think first and foremost, I think kind of being open to being a lifelong learner and seeing what's out there and
Mm.
what might help your patient is the most important, right? I think with head and neck oncology specifically, um, when patients have fibrosis and tightness and stiffness, our goal is to try to improve range of motion of, the areas that of our mouth and our throat and our jaw. And I think the first time that you introduce it to the patient, I think you can be honest and say, hey, we're starting this manual therapy program, and we've all kind of read up on it and taken some coursework, and, let's try this out. I think that's fine. And I think probably what was the hardest for me initially, which was surprising, was so much of the shared decision making. Really, kind of each step, I needed to know from them, was it too much? Was it not enough? Did they feel like it was useful? Right? Because sometimes I think patients are like, well, I'm coming in and you're the expert, so you need to tell me what to do. And then when I say, well, you are the expert of your body and how you feel, and I don't know that. So
Yeah.
I kind of upfront, I'm going to ask you a lot of questions, and let's kind of figure this out together and figure what manual therapy techniques you feel are relevant and that we'll try for you.
Yeah. And I know I talk about this in the class a lot, but shared decision making, I present in the context of manual therapy, but I also talk a little bit about the concept with exercise or movement or strengthening. How we're supposed to be the experts to tell a patient what's best for them, and that is part of our expectation. That's part of our role. That's the jacket we wear, right? But even within exercise, you can take the concept of tongue strengthening, and you can modify it to make it more unique and individualized for that person, the N of one again. Instead of just saying, okay, here's your exercise program, let's make sure that you do that.
Yeah.
And go ahead.
No, I was going to say, and I found that when I would start with someone and doing a manual technique, that I was probably much lighter in my pressure and how long I was holding something. And then when I said, okay, let's show you how to do it so that you can do this at home for your home program, that they're always much more, they want a little more pressure and holding it for longer time. So that's something that I think you need that communication with, because the first time you are going to put your hands on someone for manual therapy techniques and treatment, for me, I'm going to start with a lighter touch, right,
Yeah,
and kind of see
yeah,
what feels right, and of course understanding the treatment that they've had, right, and
yeah.
taking that into consideration.
In the PT population that I see here in my clinic, it's like so many people come in with that mindset of do what you think is best, Paul. I'm here for your expertise. Do
Yeah.
what you or do what you need to do. I can take it. And to me, that's an immediate signal to say, okay, let's chat about that, right? I do know a lot, but I don't know you. And that's why I want you to contribute. Was that a hard thing for you to transition to?
It was a little harder than I thought, because the questions were so, how about this? Are you okay with this? And just finding the spot that we needed to get into and finding the level of pressure that we could do, was a little bit more, but now it's super comfortable. Now I
Yeah,
just upfront tell them, I'm like, we're going to work together on this. This is the two of us working together. And, our goal is to improve our outcomes with respect to voice, swallowing, etc. So,
yeah, yeah. I mean, I think it's an extreme example, but a lot of people come into us almost in that I'm going in for a massage where I'm just going to zone out and they're going to do what they need to do or should do to me. And I get some prickly patients sometimes who I think they're kind of expecting that and they get a little a little ornery when I keep asking them questions. And I just say, I stand a better chance of helping you if you help me help you, right? And most I can build that incentive, but occasionally I'll lose somebody because they want somebody to take care of them. Have you come across that sort of patient?
I think I try, yes, but I think I try to frame what I'm talking about, especially with my head and neck cancer population, that the tools that I'm giving them, and I tell them, I'm here to give you tools so that you can help yourself with these lifelong changes that can happen with fibrosis and
Mhm.
tightness and stiffness. So, one time coming in to see me, if I'm working on you, that's great, but I want you to be able to do it to yourself, because then I've won. Right? I've
Yeah,
given you a tool that you didn't have before you came to see me, and now you have a tool. And I know the folks that really use it, when they come back to me and they say, oh my gosh, I have two new stretches that I tried. I got to show you. And then they
yeah,
show me the stretches, and then I pass that on to someone else. So, I don't know all, things that could work. And someone who's creative enough to kind of really work with it, I love it. And then I try to kind of pass that on. So,
yeah. And that sense of empowerment that we, not just in manual therapy, but we can build in our patients if we just, I think if we just take that professional straitjacket off and realize, you know what, I do know a lot, but maybe I'm someone here to guide them instead of tell them what to do. You know?
yeah, and I mean, in the real world in the United States, we also have to deal with insurance. So,
Yeah,
that's also an issue of that maybe they want to come in multiple times, but insurance wise, we might not be able to see them. So I kind of just bring up the reality of it's my job to give you the tools to do what you can do. But surely when we're in treatment here, we're going to work together and try to get the best outcomes. But I guess my end goal is that I don't want anyone to have to rely on me. I want them to be able to, be self-reliant.
perfect. Do you mind sharing a quick story?
Yes, I had
You
to
got
think
one?
about, I do. I have one story. So I had a gentleman, lovely, lovely gentleman, who had really bad trismus, really bad jaw opening. I think he was barely able to get one finger between his upper and lower teeth. And typical jaw opening is like you should be able to get three fingers, right, vertically between your upper and lower teeth. So um, we worked with we work with the stacked tongue depressors and kind of the tools that we typically have in our toolkit. But then once we got his jaw open a little bit more, we were able to do some manual therapy and get into like the lateral pterygoids, and he was able to get in there and stretch. And it was just a funny story, and it's one of the reasons I think we do what we do. One day he comes into the clinic and he's all smiling, and I'm like, okay, why are you smiling? And he like puts his hand in his pocket and he takes out a spoon. And I'm like, okay, what is this for? And it was just a regular spoon, but he was not able to, with his jaw opening, open his mouth enough to put a proper spoon in. So he was using pediatric, utensils for the longest time, which was embarrassing, affected his quality of life, affected his ability to socialize, all of those things. So for him to come in with like the spoon meant so much.
Yeah,
So that's, one story that I thought, oh, I got to tell Walt about that one. So
that's great. Yeah. Well, thanks for sharing that. Appreciate it. Anything else you want to say before we break this off?
No, I just think that, as a speech pathologist, I will say adding manual therapy to my toolkit has enhanced my care and the care that I give my patients. So I'm very, very thankful to you and being able to be that repeat offender to your courses because, like I said earlier, I always come out of those courses, even if I'm helping you out, with new ideas and new ways to help. So I hope that, that's what I'd like to share with your audience.
Absolutely great. Thanks so much for giving us part of your day here. I really appreciate it. And hopefully the people who are watching these videos will appreciate it too. Thanks so much.
Thank you. Bye, Walt.